Webinar this morning, which is looking at how we can work towards a resilient and patient-centered approach to kidney care in Europe. My name is Tamsin Rose, and I have the great pleasure to be your moderator this morning. We encourage you to use social media and to share your tweets, and you can see on the screen now we have a hashtag to use, which is CKD for chronic kidney disease. Patients matter, all in one. So please feel free to tag your tweets so we can follow the conversation. You can also find on this screen the Twitter and the Facebook connections for EKHA, the European Kidney Health Alliance. This is a session where we're going to have a series of different presentations, and then we'll have a panel discussion. At any time, you, the audience, are welcome to engage with us. You can use, at the bottom of your screen, you can see there's a Q&A function. Please feel free to put a comment, ask a question, and I will be putting that to the audience and to the panel. This event is being recorded, which means it can be shared later. You can pass it to colleagues and you'll be able to listen again and hear all of the details that's being shared with you. So let's start with, and I'm delighted that we are going to have a member of the European Parliament, Mrs. Hilde Woutman, who's going to give us an opening message from the European Parliament. Hilde, the floor is yours.
Well, thank you very much and good morning, everybody. Welcome to this webinar organized by the European Kidney Health Alliance. As the president of the MEP Group for Kidney Health, I'm together with our other 17 other MEPs committed to fight against chronic kidney disease at the European level. And that is necessary. I don't have to tell you how much of an impact chronic kidney disease can have on someone's life. We all know this. Every year, millions of people are diagnosed with some form of it. For many, this is the start of a long journey of struggling, falling, and trying to get up over and over again and again. And then, out of nowhere, came the COVID-19 pandemic. It shook up our world. This is all the more true for chronic kidney disease patients. Don't be mistaken. They're not just a high-risk category. The numbers show that they face a way higher risk of getting ill. And moreover, the mortality rate is higher than people with other risk factors. We saw during the first wave that many patients face difficulties in access to care. Sometimes there were even shortages of dialysis material. This is unacceptable, and we must ensure this can never happen again. So what can we learn from this COVID-19 pandemic, and how can we make sure that we are prepared for similar scenarios in the future? Honestly, I don't have a straightforward answer to that. Nevertheless, I'm an optimist that believes in progress and change. We can do more for patients with chronic kidney disease, and we have to do this at the European level, because as we all are witnessing, diseases know no borders. The need of European cooperation is greater than ever. Luckily, there are some good things in the pipeline. The EU for Health program, for example, includes concrete measures aimed at strengthening prevention, digital health management, and care of chronic diseases. During and after the pandemic, the legislation is not there yet, but I'm sure it will benefit a lot of chronic kidney disease patients in the future. Also, next month, the European Commission will publish a new report on the way forward to a European Health Union. Hopefully, they will take into account the lessons to be learned from the first wave of the pandemic, including the added value of home therapies, digitalization for patients, and the crucial need for data harmonization and sharing it at European level. Yet, we have to admit that the fight against chronic kidney disease is not visible enough in the EU research priorities. We have to change that, because research projects on next generation renal replacement therapies are crucial. The impact of COVID-19 on dialysis treatment and the difficulties it poses to patients is obvious. But although life-saving, dialysis is not the ultimate and final therapy. Even before COVID-19, it remained associated with high mortality, high cost, and a relatively poor quality of life. We really need better and more innovative technologies. Luckily, we have seen a lot of progress on the other side of the Atlantic with the US Kidney Health Initiative. It is our job to convince the European Commission to do the same. That is my goal. Working together on all possible levels and further improving the life of all people with kidney disease. Together, we can and will make it happen. Let's make this decade the decade of the kidney. Thank you very much and good luck with your webinar today.
Thank you very much, Mrs. Woutman, with a very strong political message and the importance of putting kidneys high on the agenda. And we do have, we hope that the Commission's proposal as it comes out in the next few weeks is both ambitious in its scope, its budget, and its approach to prevention and managing chronic disease. So now let's spend a little bit of time understanding what has been the impact of COVID-19 on kidney patients. COVID-19 has been in the headlines since March. Our lives have been completely transformed, and we're never going to go back to how we were before. Europe is in the grips of a second wave, and other parts of the world are also experiencing a resurgence. So there's no light yet at the end of the tunnel. But there will be a life post-pandemic. So this morning, we're going to be understanding what has been the impact on patients and care, and how do we organize things more effectively. So let me start by passing the floor to Daniel Gallego, the president of the European Kidney Patient Federation. What would you like to share with us about the impact of COVID-19 on kidney patients specifically?
Yes, sorry, good morning. A privilege and an honor to be here today with you and to share with you all the impacts and all the outcomes that we have learned about the COVID-19 on the kidney patients. Of course, I'm a kidney patient undergoing hemodialysis. Luckily, I'm the luckiest one of the hemodialysis at home, but believe me, we have a lot of people with kidney health conditions across Europe. We are talking about 75 million people with that have a kidney disease, which is the 10% of the population. We are talking about the advanced chronic kidney disease plus 25 million of people. Of course, the number are here because this is the registry of EDA of the 2017. Home therapies, we estimate that we have more than 30,000 people. In transplant, we have across Europe 240,000 people. And of course, the worst group in hemodialysis, we already know, we have these numbers. That is, of course, the numbers are bigger for sure nowadays. Talking about the ACKD, the advanced chronic kidney disease, which are stage 3 and 4, they have the immune system affected, and at least 20% of people have a serious symptom. 80% maybe have only moderate symptom, but believe me, 20% of about these numbers at the higher risk, and they should or have to stay at home, but they must keep taking their medication because they have hypertension, obese, they are diabetics and fragile. So this group is a high risk group. Talking about the kidney transplant, they are immune compromised, they have risk to pneumonia, they have their regular revision postponed, and the medication is at hospital. It's not easy sometimes to get the prescriptions and the medications. And maybe as you know, the activity of transplantations have fallen until 80%, and we only have emergency transplant during the first wave. And we have to wait 20 days for donation if you are infected with the COVID-19, and in the living donors at least 3 months. So they have to stay at home and to take the control temperature. Regarding the home therapies, We are the luckiest one, as I have mentioned, because all the consultation are with telemedicine in home assistance. We are the home supplies guarantees, but we need the protocols to guarantee the home supplies and all the reception and with protection. We have seen the peritoneal dialysis catheter surgery without priority. We have to wait for these interventions. And we have seen that the home therapies are the safest treatment during the pandemic. And regarding the hemodialysis at center, this is a stage 5. They have to undergo 3 times a week, 4 hours. So the recommendation is the own vehicle without companions. With this public sanitary transfer in a collective transport is not the safest, as you can imagine. We don't have waiting rooms. We have a lot of measures of protections without food service, and we have seen how the hospital has been organized in 3 separated shifts, free of COVID, suspect, and infected. So the situation about the concerns about the COVID-19 of the kidney patient, as you can see, the kidney replacement therapy patients, which are dialysis patients and transplant patients, we are in panic about the personal safety, because it's not easy to access to medication. We have delayed the vascular access surgery. We have an isolation, and we have seen an unclear public health guidance. And of course, we are affected by emotional disorders. We should address that. Regarding the advancing chronic kidney disease, we have seen a delay or postpone all the consultation and diagnosis. We have seen trouble to access to healthcare professionals. We have the same unclear public health guidance, and of course the treatments, and we have seen worsening health in this group. We have clear paradigm shift changing the landscape, because hemodialysis patients are not able to remain safely in their homes. So the hospital and dialysis units are not the safest place. So with the kidney transplant, we have seen reduce on only emergency, and COVID-19 patients can become big kidney patients. So we have to see these improvements by telemedicine and the regular consultation by home. But we have to be careful with the telemedicine, because elderly people and people with disabilities are not able to use the telemedicine and the new technologies. No? And of course, the access to medication is not easy remaining at home. So besides that, the temporary unemployment and the telework is sometimes the best advice to the kidney patients. Regarding the patient organization, we are trying to continue offering support, avoiding the social exclusion, trying to promote the mental well-being and nutrition. But we have, as a patient organization, we have changed the organization focus, because our concerns is over the organization financial. No? We have to renegotiate milestones for projects undertaken with owners, partners. So we have seen a lot of changes. And what would we like as kidney patients, or what would we want? Of course, a social protection to kidney patients, always rating medical inclusive, do not discriminate against age, disability, or chronicity, because every person has the same social value. So we will want to consider kidney patients as a risk group and vulnerable. Of course, the hospital medicines could be delivered in the pharmacy community, maybe with home delivery. Reconsider, we used to go unreasonable to the hospital and dialysis unit. So guarantee, of course, all the supplies and all the medicines. Of course, maybe we can enable an automatic prescription and renovations in primary care, direct communication by phone, and of course, develop telemedicine, phone consultation, and postponement, better data collection, and of course, telematic assistance and virtual support, but taking in account always the people with disabilities and elderly people. We would like to have clear protocols to prevent and manage COVID-19 in dialysis unit and home therapies. We have seen the safest therapies are the home therapies, and promotion, this rise awareness about family and caregivers, because they are the best person to try to prevent and protect with all the kidney patients. And finally, collect all the best practice guidance in COVID-19, everything that had worked for kidney patients, with best coordination between countries and between institutions. And thank you very much. This is the Take Kidney Home's message, because we are in the arena, we are struggling and fighting every day with the kidney patients. If we have seen a disruption in our care quality, is because we don't have developed in time the telemedicine and the pharmacy backup. We would like to have better data collection and registry to secure access to kidney replacement therapy, promote the home therapies, be evaluated and be considered as a high-risk group. And of course, we would like to have a priority in the access to vaccine where we are able. And thank you very much for your attention.
Thank you, Danielle. You gave us a very good overview of the range of different types of patients in the kidney disease area and how they were each affected in different ways. And a very important reminder at the end that as we're looking to come out of the pandemic at some point in the future, and there'll have to be decisions about who would be a priority group for a vaccine, to put kidney patients high up there on the agenda. Let me now pass to Professor Raymond van Hulder, because you're the president of the European Kidney Health Alliance and a clinician working in this area. We've heard from the patient perspective. What are you seeing in a clinical perspective as the link between COVID-19 and kidney disease?
Okay, good morning, everybody. It is my task to explain to you the importance of COVID-19 and how it affected the population with kidney disease, which is a fact that is unknown to many people outside of the nephrological community. Before starting, just briefly who we are. The organizers of this webinar, European Kidney Health Alliance, advocates for the patients' needs and the nephrological community. And we are joining together physicians, nurses, also patients and foundations in this European group. And also, before starting, just briefly, an overview on the burden of chronic kidney disease at large, even irrespective of COVID. And again, a number of data that are unknown to many people and also to many policy makers. If we ask the question, who does suffer from chronic kidney disease, and we take 10 people, then at least 1 in 10, according to some sources, 1 in 9 is suffering from chronic kidney disease, which means that more than 75 million Europeans suffer from chronic kidney disease. And more than that, 1 in 3 is at risk of chronic kidney disease with diabetes or hypertension or cardiovascular disease, but we just simply do not know who of them will develop chronic kidney disease and who not. On top of that, this is an extremely devastating disease. On this slide, you see the 5-year survival of a number of end-stage kidney disease treatments. These are the modalities that are given for people with advanced kidney disease, either hemodialysis or dialysis at home or transplantation. And I ask you to focus on the 2 bars that are surrounded by the red rectangle. The red one on the left is the 5-year survival of hemodialysis patients, in-center hemodialysis, which is the mostly used way of kidney replacement therapy in Europe. And on the right side here in blue, you see the overall cancer survival. So it is clear that mortality in patients with hemodialysis in-center is much higher than the one of all cancer patients. And in fact, dialysis is only preceded by 2 specific types of cancer, that is pulmonary cancer and neurologic cancer. And on top of that, this is also an extremely expensive disease. Here are extrapolated costs for chronic kidney disease on the right side and those for cancer in 1 year on the left side. So it is clear that these expenses are much higher, or at least the same as for cancer. Again, something that is not yet very well known, so that we need more research and more active policy to improve the conditions. In this already heavily affected population, the COVID-19 disease struck very hard. And again, this is something that is unknown to many, and of which you find only little trace in literature. And that is also in part perhaps because the original Chinese data were quite misleading. Here you see one of the largest series on Wuhan, where you can see that less than 1% of their hospitalized population is reported to have either chronic kidney disease or kidney replacement therapy. And it's only later on, first starting with the data from the US CDC, this was end of April, beginning of March, that the conditions were completely different. On the left side, you see the percentage per chronic disease of hospitalized patients. And on the right side, you see the percentage of people hospitalized or admitted to the intensive care unit, which are the most severely affected patients. And the chronic kidney disease patients are in blue. So it is clear that their number of hospitalization and also their number of ICU treatments is much higher than for the other chronic diseases, be it cardiovascular disease in red or diabetes in green, or other chronic diseases in purple. And that's not all. Also, their mortality was high, extremely high, actually, again, the highest of all other populations. And here you can see the mortality of transplant patients and dialysis patients with COVID-19 for European, all over European data by the registry of the European Renal Association. And as you can see, these are 20%, 21% for dialysis patients. And in fact, we have seen data that even were higher. For instance, for my own region, which is Flanders in Belgium, there soon are going to appear in Journal of American Society of Nephrology figures of 30% mortality among dialysis patients. But not all these patients on kidney replacement therapy are in the same conditions. The treatment can be done as hemodialysis, as already explained. That is mostly done in Europe in center, and that is also the majority of people with kidney replacement therapy, about 60% all over Europe. Then there is the patients who are treated at home, which is mostly peritoneal dialysis through the abdomen. But that is only about 10% of the European dialysis population. And then you have the remaining group, which are the transplant patients. And these are data for the first wave in Italy. So the hue of the colors is indicating the distribution of cases along Italy. And then you can see that this distribution is fairly similar for hemodialysis or peritoneal dialysis or transplantation. But if you look at the mortality risk, and that is what is surrounded by the red rectangle, again, for in-hospital hemodialysis, the mortality is about 3 times higher than for those patients who are treated at home. And also for transplant patients, mortality is lower. So the only conclusion we can draw, and that will be also one of the main conclusions of this meeting, is that there should be a shift of paradigm in the organization of kidney replacement therapy along Europe, shift from in-center hemodialysis to home dialysis and to transplantation. And there is this other problem that is often forgotten and not talked about. There is also another form of acute kidney injury, of kidney failure, acute kidney injury, which is not developing over years, but in the course of a few days or even a few hours. And those are the most severely affected patients. And in this series, you can see that among hospitalized patients, more than 50% were developing acute kidney injury or some form of acute kidney injury, and that among those, more than 30% were dying. So this is another group that is severely affected, and that for a large part is likely, if this survives, to evolve into the direction of chronic kidney disease. And here below, in the dark blue color, you see the mortality of no acute kidney injury, and then different degrees of severities, from less to more severe. So you see this mortality rise, and in the most severely affected group, which is also a group that will need dialysis, usually mortality again is more than 50%. So this is really a severely affected population. In the margin, we saw appearing another number of problems. One was shortage of dialysis material that was reported from the New York area, but which probably could have been avoided with better knowledge of the disease, and also better organization, planning, and knowledge of the different treatment modalities. And on the other hand, which was there all over the world, shortage of protective material for the personnel, which put them at high risk of being infected themselves. We must realize that in-center hemodialysis is a kind of a closed community, and that as a consequence, all people that are in contact with each other are at increased risk, included the transport of the people to their dialysis unit, which usually is 4 or 5 patients together with a driver. So this is another reason why the disease was spreading among this population. And apart from that, and just to be complete, a few other points, the higher susceptibility of immunosuppressed patients to infectious disease, so also the higher risk. That is not only covering transplant patients, but also a lot of chronic kidney disease patients that are inflammatory, and where the patients are receiving immunosuppression, which is a big source of stress for them. The decrease in transplantation rates, with a huge drop in almost all countries along Europe, with very slow recovery. Some countries were faster, like the UK, but I know that here in Belgium, at the end of August, the figures still had not recovered, and that is all due to a shift in scope of the ICU in the intensive care units, which will be a problem now again during the second wave, because we must realize that there is a second wave coming, and after that probably other infectious diseases that will be even more severe. Then there was the postponement in many countries of PD catheter insertions that were considered as being not urgent, although they are urgent because people need to have dialysis therapy, and that forced them to go into in-center hemodialysis, of which you now will already have understood that it is not desirable. And there is also the risk for the personnel, already touched upon, the close contact with patients and their infection risk, which also caused dropout due to disease, but also due to work overload and burnout because of the stress and the fears of getting the disease themselves. And finally, a universal problem that, as a matter of fact, is there already since many years, the exclusion of kidney patients from therapeutic studies, but that will be now even a bigger problem because of the heavy affection of this population. So if they are excluded from treatment studies and also from vaccine studies, we once more as nephrologists will be confronted with being forced to work in the dark as blind people, or to go for off-label treatment. And also this issue clearly needs to be brought to the attention of policymakers. This is all I wanted to tell you. I thank you for your attention.
Thank you very much. You've given us a very sobering view of the impact of COVID on kidney patients and their environment, and raised the alarm that patients with kidney disease are not necessarily being included in clinical studies, which is critically important going forward. So thank you for that. And as a reminder to everyone who's watching, the PowerPoints from this will be available for people to download afterwards, as well as the full recording, because there was so much information in those first two presentations. I'm sure people will want to watch them again and read them. So now let me open the floor to a panel, and I'm going to introduce our panel, and then we're going to start. The first section is going to explore what are our lessons learnt and the future prospects we've got to reduce the chronic disease burdens for patients in Europe. So here on your screen from left to right, Stefan Schreck from the European Commission, DG Santé, Professor Edwina Brown from Imperial College in London, the Hammersmith Hospital, specialist in renal and transplant centre and a nephrologist, Professor Fokke Weringa from the Connected Health Solutions of IMEC in the Netherlands, Professor Ronald Gansvoort from the Division of Nephrology, the University of Medical Centre for the Netherlands and the European Renal Association, and Fiona Loud from Kidney Care UK, leading the patient organisation. So the first person I'm going to go to is Professor Edwina Brown. We heard in the first session about how patients who had dialysis at home or home treatment did better. And this is something that you've covered in many of your publications. You've talked about underused therapies such as home dialysis and how that could reduce the high societal costs as well as improving quality of life. What have we learned from COVID-19 about how these other therapies could be used?
Well, thanks for including me on the panel. I think the main thing that we've learned is that people with advanced kidney disease can be managed at home and not have to come into hospital. We had a very high death rate and incidence of COVID in our hemodialysis units, which left my hemodialysis colleagues and the administrators in the hospital traumatized. So we have gone from a limited PD population to a policy of PD first. And that has enabled people to stay at home. And this is important both for younger people who want to shield and not be exposed to the risk of COVID in hemodialysis units. And it's particularly important for our older patients who really are at high risk of getting COVID. We've been managing them at home. We manage them in nursing homes with assisted PD, which I think is absolutely essential at this time. And that enables people to be kept in their homes. The other thing that we learned is the advantage of just using adapting peritoneal dialysis to residual kidney function. So you could deliver a sort of fairly simple peritoneal dialysis using 2 or 3 exchanges a day, which is easy to train people and to provide the assistance needed to keep people in their homes, avoid transport to hospitals, and be relatively much safer during the COVID time.
Thank you. And you mentioned something that was picked up earlier by Daniel Gallego, talking about the challenges for patients who need to go into hospital for their care for dialysis, and yet in the hospital they're exposed to greater risk, both in the transport to hospital and in the care that they receive. So let me now turn to Fiona Loud. Your organisation, Kidney Care UK, has recently done a report on the impact of COVID-19 on people living with kidney disease. We've heard some of those elements highlighted earlier, but what do you think, from the patient perspective, should be the main lessons that policymakers should be drawing from all of this? Professor Edwina Brown said one clear shift, and from a clinical perspective, is PD first or assisted PD. What do you think, Fiona, are the lessons that policymakers should be taking from this?
Thank you, Tamsin. And I have a couple of slides, actually, if colleagues were able to share them. Thank you. So we've actually now published 2 big surveys from kidney patients, very sobering, as everybody else has said. The first showed the mental health impact, as people can clearly see there, 4 out of 10 people reporting that. Nearly 7 out of 10 reporting disruption to care, and 1 in 4 with worries about getting access to food itself. So some of the basic things were of concern there. Great confusion over the government advice and perhaps lack of clarity there. And we also learned that family members, unsurprisingly, were very concerned too. So they chose to isolate along with their loved ones. We could just move on, please. We also ran, we've just published something this month called Out of Sight, Out of Mind, which is yet another patient experience survey. And it shows that that disruption in care still hasn't yet returned. And of course, we are now, still continues, should I say, and we are now heading well and truly into the second wave. So people are very concerned about that. People are very concerned for their safety, but many people in the sort of lull between the first stage and now the second stage have had to return to work. And some of them have not been able to get the adequate support from their employers. So they are in some difficulties around whether to work or not. And I'd just like to also bring out the serious financial impact on patients and their families of this pandemic, and the ongoing mental health crises, which I'm sure many of our medical colleagues and patient colleagues will have noticed. So if we could now just, my final point, the next slide, there's some lessons for leaders. So, whoops, the previous one, please. So 100%, everybody wants and needs timely, clear advice that they can understand, and they are also in need of support and protection at this time. Please don't make the health service a COVID-only service, because many people felt that they shouldn't be bothering staff at this time. And fear and anxiety, I think we need to acknowledge that that exists, and that is probably getting in the way of people perhaps accessing care. And that the inequalities that MEP Voutmans and others spoke about very clearly are very clearly highlighted by this, by the pandemic. Please also, to leaders, give financial support so that clinically vulnerable people don't have to choose between their jobs and their health, and do work with us. And of course, I completely agree with Professor Brown's last comments about safety and home dialysis as well. But from the patient point of view, I hope this highlights those points. Thank you.
Excellent, thank you. So again, you're highlighting some of these very strong impacts on people, and it's clear the message was very strong in every country. You know, protect your health system, stay out of the hospitals, etc. But as you say, that there's a risk that then the perception is they're COVID-only facilities, which is a perception fueled by the media headlines of overflowing hospital beds, etc. Which means that people are dissuaded from accessing care.
This happened, definitely. Yeah.
Thank you. Let me now turn to the next person I'm going to bring in, and I'm going to invite Ronald Gansford to pick up on this one, because if you need to understand what's happening in your health system, you need interoperable and reliable data that allows you to do effective policy responses. And you've been involved in the ERA EDTA registry and something called the ERA CODA database. Can you tell us a little bit about them? They're examples of data pooling and sharing mechanisms across countries. And I think that's one thing that the COVID pandemic has really emphasized to us. We can't deal with this alone. We have to share our knowledge and our data, but the data's got to be effective in the way that we do this. So Professor Gansford, tell us about those two initiatives, and what do you think we could learn from that?
Yeah, thank you for inviting me to this interesting webinar. And let me first start explain what the ERA EDTA Renal Registry is. That is an organization that was established by the European Renal Association, and that collects data on the number of patients living with a kidney transplant or on dialysis across Europe. And it collects data on numbers, but also on outcome of these patients. And that gives us important insights on what happens over time with the epidemic of chronic kidney disease across Europe. It's important to note that participation is voluntary, so not all countries in Europe participate. And I think that's one of the disadvantages of a voluntary system. For instance, Germany, and that's one of the largest, if not the largest country in the European Union, does not participate, and we don't have any insight on the number of patients with end-stage renal disease in that country. And this database has also been used to give information on the impact of the COVID-19 pandemic, and it offers important lessons. For instance, that the mortality in patients on dialysis and transplant was very, very high. Disadvantage of this system is that it allows only very limited data set to be collected, and to get a better understanding of COVID-19 and the impact in our patient groups, we need more detailed data. And for that reason, as European Renal Association, we started the ERA CODA database. And that is a kind of collective research organization in which now more than 200 kidney specialists from all over Europe participate. We've got data of more than 2,000 patients on dialysis or a transplant, and that had COVID-19, and we've got very detailed granular data. And we learned important lessons from this new database, and that is that, for instance, the risk profile in our patients is completely different from the general population. We know from the general population, for instance, that diabetes, hypertension, and chronic heart disease are very important risk factors, but in our patient populations they are not. It is associated with zero risk. So when we're looking at patients and we have to decide as clinicians, who do we admit to the intensive care unit? I know that many of my intensive care colleagues think it is a dialysis patient. He is male, has diabetes and also heart disease, and they think the risk of this patient is so high that they should not be admitted to an intensive care. But in fact, it is only the fact that this patient is on dialysis and is at a certain age that counts, and all these additional risk factors that do count for the general population do not count for our specific patients. So there should be specific risk engines to estimate the risk in our patient population to decide who can be admitted to an intensive care unit and who should not be.
Okay. Thank you. I'm still trying to process some of your messages because they were quite complex to understand, and I'm sure we'll have some members of the audience who would like to pose questions, and a couple have already come in, and I'll pass the floor to our panelists to answer them in a second. But let me keep going through a first round of our panelists, and I'm going to turn to Stefan Schreck from the European Commission. The European Commission was at the forefront of coordinating the European response to COVID, working directly with the European Council, very high profile, big task. What can you tell us from the inside of the European Commission's thinking? How did chronic disease is not something new. The Commission has been working on this for a while. How did the COVID-19 pandemic affect the way you addressed the chronic disease agenda? And if there's anything you can tell us specific about chronic kidney disease, that's very helpful. Stefan.
Yes, thank you very much for inviting me to this panel. Yeah, and
I think we've lost you, Stefan. I can't hear Stefan at all. Can any?
It looks like he got muted somehow.
Yes, but he doesn't look like he's mute. Stefan, I'm sorry, we can't hear you. Okay, if let's see if we can try and fix the sound, and while we do that, let me pass to actually this is an issue. We still need to find out why Stefan can't hear us or keeps trying to talk. So in the meantime, let me ask the other members of the panel. In many areas, we went to digital, and this was a very fast shift, almost overnight. A lot of care had to be delivered. What do you think we can learn? Which digital tools were useful for chronic disease patients? And what should we then say now this should be the way forward? Because it could be something as simple as digital consultations. It could be something more complicated. It could be apps to follow them. Where have we found digital tools stepped into the gap and provided real value and should move forward? So let me start with Edwina, and in the meantime, we'll try and see if we can fix the problem with Stefan. Edwina, Professor Edwina Brown, would you like to tell us, did you use digital with your patients? What was good? What worked?
Absolutely. It was a very sudden shift into the digital world, both for us as healthcare providers and also for the patients and for the NHS. So I think what's worked really well is, first of all, the existing remote monitoring that already happened for peritoneal dialysis cyclers. So that meant that we could see what people were doing at home in terms of their dialysis. And that obviously gave people a lot of confidence, particularly new starters, about that we could see what they were doing and we could help and advise them. And it really enabled the phone consultations that took place. What we don't have is similar digital technology for the manual type of peritoneal dialysis, the CAPD. I am aware of companies that are trying to develop this, and I think we really need to push that forward rapidly so that we trial this technology, so that we can see equally what our CAPD patients are doing, as well as people on cyclers. The NHS was forced to produce a video technology so that we could talk to patients rather than just by telephone, and that was escalated through extremely quickly. It would have taken years otherwise, and that has been useful, but limited by patients rather than by clinicians, because a lot of patients don't have smartphones or good internet access. And the other thing that's worked well is being able to see blood test results when taken in different places. So blood tests remain a major problem in terms of both patient access to getting their blood tests and us being able to see the results. And certainly locally, we can see in some hospital, other hospitals, what patients' blood, and that is helping, but needs a lot of work.
Thank you. Fiona, I saw you were nodding there when Professor Brown talked about the challenges of getting blood tests and others. I was moderating an event a couple of days ago with respiratory doctors, and they said, when you have a video consultation, I don't have a stethoscope. I can't listen to somebody's chest. So the basic functionality of the first consultation can't happen, although there are some new apps where you can blow into a smartphone and they can do some peak air tests. What, from your perspective, what were the digital tools that were rolled out that were useful, that you think should become standard for the future?
Indeed, thank you. And I was nodding to that because that was absolutely one of the points I'm going to make. I just, again, got a couple of small slides just to go with this. So we do already have an online system called, it's called Patient View, which is now upgrading to something called Patients Know Best. And if you take a look below, you can see a snapshot from Patients Know Best. So that's one of my recent blood results on there. So I can go in and I can see after my blood test what things look like. And that has helped us to develop some expert patients who have the access to be able to do that. But you really do need practical ways to get blood tests. It's fantastic to see something online, but if my blood is not in there, it's fairly meaningless. So if we could just go on to my second point there, please. Second slide. Now let's talk about Dr. Zoom. Dr. Zoom is not for everybody. So very rapidly, we have indeed developed more phone consultations, more video consultations, and many patients think that is convenient, though I've had a little feedback from some patients about trying to, and I'm sure it's the same for clinicians, about timekeeping, etc. But the ask is, don't replace face-to-face for everybody. So don't, in other words, get so carried away with the interest in digital and the convenience of that, which I personally would find very convenient, because it is not for everybody. I've already explained how some patients felt that they hadn't been talked to for a long time, or felt they didn't want to bother anybody. So that element of choice, so the patients are not out of sight or out of mind. It's also much more effective when you already have a relationship with the clinician to have a more remote consultation.
So I'm unmuted now.
Okay, thank you, Stefan. Shall I just finish my point, if that's okay,
Yes.
Tamsin? Great.
Yes, please, go ahead.
And so just also to remember those inequalities that Daniel spoke about earlier as well. There is a digital divide. Not all patients are able to access or comfortable with accessing these technologies. So for them, and for others when they need it, please make sure that that choice is available. And remember that actually don't presume that everybody has the skills, so offer training to go along with it for people. And remember, there is a cost for people to be able to have the internet and the smartphone and so on. So good opportunities, but let's make the best of it together.
Thank you, Fiona, and apologies that we lost your sound, Stefan. You can now come back and share with. We lost. I'm afraid we could see you speaking, and you were saying lots of things, but we lost you after. Thank you for inviting me on the panel. So I'm afraid you have to repeat everything you were saying to us.
Yes, the wonders of technology. But I've actually stopped my video, so I guess then the bandwidth will be enough, at least for what I say.
Yes.
Yes. So what I did say is actually coming back to the agenda of the Commission. I did say that actually COVID-19, of course, was top priority, or still is top priority. There's absolutely no doubt dealing with the direct effects of the pandemic. But we actually did not forget about non-communicable diseases. It is a clear lesson learned, I would say, from this pandemic, that it is not enough actually to deal only with the infectious disease, but that actually dealing with and improving the situation of patients suffering from chronic diseases is also very important, because they suffer from higher mortality and morbidity that is actually created by COVID-19, but they also suffer indirectly because of the effects COVID-19 has on the health systems. But some of those people speaking before me have explained this already, so I'm not going to repeat it. So, but what I wanted to say is, so of course, while our priority is dealing with the pandemic, we also learned that indeed prevention and health promotion is also a very important part of pandemic preparedness. So actually, the healthier people are, the less they will be affected by the next pandemic. And this is also, you can see this in the Commission's proposal for the EU for Health program. So the EU for Health program, while it really focuses on the effects of the pandemic and preventing the next one and better preparedness, also has a very important and improved part on non-communicable diseases compared to the old programs. Indeed, we are still committed to the WHO's objectives on chronic diseases and non-communicable diseases. That is quite clear. They got even more important. You can also see that we did not stop work on the European Cancer Plan, for example. So work on non-communicable diseases goes ahead as planned before, and hopefully even more so with the help of the new EU for Health program. But that is under discussion. As you know, you will certainly have noted that this is not yet finalized. Specifically, I actually said, sorry that I now have to repeat everything, but the methodology we now apply is actually the direct result of the role of the Commission in the EU treaty, because member states are in charge of their health system. They are responsible for protecting their patients, they are responsible for prevention, they are responsible for their health systems. But we do our best to support them in doing that. And we have created a new group already a couple of years ago. Can you still hear me?
Yes, we can. Go ahead.
Okay, yes. So that group we use to discuss with member states priorities in the area of non-communicable diseases. That is a very productive process, as we have seen. And now we will do it. We are currently in the process of doing this in the light of COVID-19 for the next couple of years. What we also do is we have created a new portal for best practices. So where everybody can actually submit practices, and if you are having practices to help the healthcare systems to better care for CKD patients, then you would be most welcome actually to submit this to our portal. It will then be assessed by experts. And if it's found to comply with our criteria for best practices, then it will be presented to the ministries of health in the member states. And we will ask ministries which of the best practices they would like to implement in their country, and then help them to do this with support from the EU budget, from the health program, but also other programs. And that is really something where everybody who knows good practice can contribute by submitting it to our portal.
Okay.
Yes, just to mention one more point, what we are concretely doing, because we have also noticed that COVID-19 has a severe impact on mental health, both for the general population, but in particular for chronic disease patients and certainly also CKD patients. And we have created a new group under the health policy platform for this specific issue of mental health problems created by the COVID-19 pandemic. And there are already many organizations participating, and you might also be interested in checking out our website, the Health Policy Platform website, and maybe even to contribute to that work or learn from the exchanges which take place there already. I think that was my short version now. Sorry for that.
Thank you. And just before I pass the floor away from you, we have had one input from the audience that suggested another area where there might be a role for the EU, which is the upcoming evaluation of the Patients' Rights Directive. Is this another opportunity to pick up some of the challenges that we've spoken on? Is there anything you can tell us about that, the evaluation of the Cross-Border Patients' Rights Directive?
Not much apart from that. It's indeed taking place, and I know that, of course, the colleagues who are working on this evaluation are, of course, also totally aware that this needs to be done now in the light of the special situation created by the COVID-19 pandemic.
Right.
Of course, you need to be aware that the legal basis for such a directive is really at the borderline of what can be done under EU law currently.
Okay.
And there really everybody needs to be aware. Maybe that will change in the future, because even the EU treaty in the area of health, there might be a chance that this is rediscussed as part of the overall discussion on the future of Europe, which is planned.
Great. Okay, thank you. I'm now going to turn to Professor Volker-Wierenga, because I'd like to pick up on this issue of tools, and also we know that from everything that's just been shared, the close relationship between kidneys and COVID-19, particularly some COVID patients who've developed acute kidney injury and that then need therapy, and also that kidney patients were more affected and had higher mortality rates. So we clearly need to up our game on kidney replacement therapies. And you could share with us the US Kidney Health Initiative. Tell us what they've been doing. Do you see a potential for something like that in Europe?
Yes, I indeed do. And I'm at the moment also kind of a bridge between Kidney Health Initiative, US and Europe. Well, first of all, I do agree with the previous speakers that home dialysis will rise and telehealth will do. And because also the healthcare workers themselves now use telepresence to communicate with their families and see how they are doing. So they understand the need for both sides. But that's a side point. Let's go to the next one. Next slide, please. Yes, so previous one, please. Yes, the Kidney Health Initiative has done a great job on making a technology roadmap for innovation. That, I think, is a great achievement. And this is not only a US roadmap, it has been filled with recommendations from experts internationally. Next slide, please. And what they also did was they made a funding mechanism, the Kidney X prize, Kidney X competition for alternative kidney failure therapies. That was done by US government and private partners. And so they can take that roadmap and they say, if you achieve a milestone in that roadmap, we'll fund you, which is a very interesting approach. Next slide, please. Now, if we then compare the European Kidney Health Alliance from our side, here shown to the left, and we see that we have an excellent relationship with the European Parliament. Next, click please. And the members of European Parliament Group for Kidney Health, as Hilde just this morning already showed, is highly driven for kidney health. Now, in the American side, if we click, we have the Kidney Health Initiative, which also is a kind of a similar roundtable with similar parties, and also has an excellent connection to the bipartisan kidney caucus from the US Congress. So that's an interesting similarity. And I didn't draw these two. These two were drawn by the organizations themselves. Look at the similarity. Now, if we click next, we can see, please click. Yes, we see the roadmap that has been made by Kidney Health Initiative, but also with input from European parties and experts. And on both sides, we clearly want to improve patient survival and better quality of life. That's obvious. Click, please. Yes, and we also involve, and I've been doing that as a technologist from IMEC, a Technology Research Institute. We have established with FDA KidNew, and we also involve the European and the American and even the International Federation for Artificial Organs, the tinkerers, inventors that are working on better artificial organs that might even be implanted. Now, if we click again, what we see then is that from both sides of the Atlantic, from Kidney Health Initiative and from European Kidney Health Alliance, we clearly share the same goals. We want to improve this patient survival and better quality of life. And to that purpose, the Decade of the Kidney was declared by the American Association of Kidney Patients and also has been connected with the European Kidney Patients Federation. So we both have that same goal. Click, please. And there we see that the funding mechanism to really achieve that goal has been established on the American side already with KidneyX. Click, please. And unfortunately, but we're working on this, as we heard Hilde already say this morning, the EU Innovation Accelerator on our side is still missing, a dedicated innovation accelerator funding mechanism from the EU side. But I'm convinced that we are going to fill that gap, and in that way can build this transatlantic bridge and really get somewhere together, because diseases, as Hilde said, diseases know no borders, and we should work on this problem together. Thank you very much.
Thank you. I mean, the slide got more and more complicated as you added more things in, but we could see where there is a gap, that in Europe there's a gap in the follow through and in the sort of financial mechanisms that would allow these innovations to go forward. And I love the idea of tinkerers and inventors working on the sidelines of health, coming up with new ideas for kidneys. I'd like at this point to pull in a couple of the questions from the audience, because we've had quite a lively set of inputs here. And a couple of the questions I'm going to ask them. The first one is very simple for answer. Marion has asked, can we share the link to the best practice database that Mr. Schreck has talked about? Yes, absolutely. We will invite him to share it in the chat, and we will make it available to everyone, because I'm sure people will want to both submit and use the database. So that's an easy question to answer. We have a couple that are, and I think maybe the first ones would go to Professor Van Hoven, because here they relate to some of the statistics you presented at the beginning, where it said, am I understanding the statistics correctly that the incidence of CKD are higher than cancer, and the 5-year mortality is higher than cancer average, and the economic burden is also higher? That was one of your earlier slides. Are you able to respond to that?
Yes, sure. I also responded in the chat box already. So to avoid misunderstandings about incidence, actually, first of all, it's more about prevalence. I showed prevalence data. This is CKD at large. That's smaller than of cancer. There's 1 in 3 people with cancer. There's 1 in 10, 1 in 9 with chronic kidney disease. The second one about mortality is not CKD at large, but is dialysis and transplantation. So it's kidney replacement therapies. Their outcomes are worse for dialysis, are slightly better than for cancer in transplantation. And of course, the data for CKD are not very well known, but we know that their mortality is also increased. That explains that there are 10 times more CKD patients, or even 100 times more CKD patients than there are patients on dialysis. It's just because they die in between. The third one is overall for CKD. And there, as you have seen the slide, you could say that the costs are higher for CKD. These are extrapolated data, so one must be careful. There may be some noise on it, but even if the noise would be very important, then still the figures are very striking. And to my opinion, as up to now, not known to me.
Could I just clarify that the data you've been talking about, in terms of the costs and the mortality, it's in relation to COVID-19?
Yeah.
Yep,
Yeah,
okay.
No. That's all under normal conditions, irrespective of COVID-19. So if you understand that on top of that, COVID-19 was more fatal for kidney patients than for any other population, that would increase the mortality for the running year. That there were more therapeutic interventions needed for complications, and more acute kidney injury that would increase the cost. So that you have to keep in mind as well. And that probably in the late consequences, all those patients with acute kidney injury, a number of them will also become chronic kidney disease patients.
Okay, thank you. We've got a question, I think, and maybe it's quite an easy one to answer. That I think I'm going to direct to Professor Ron Gansvoort because it's about data. It says, what's the message for Finnish healthcare? We still have very low numbers of COVID-19 patients compared to Europe, but we also send data from the Finnish Kidney Register to ERA EDTA, and because it's about ERA EDTA, that falls on your shoulders. This is the issue here. Are we getting the data from all of the different countries? Because I think you mentioned that we've got no data at all from Germany. Why is that?
Yes, that's one of the big problems, I think, in Europe is sharing data. And, we have been in close contact with our Finnish colleagues. Unfortunately, they don't have much COVID-19 yet in Finland, but they do have some patients who would like to share the data with us on a European level, but it's quite difficult for them. The burden they have to take to get that data transferred to our database is huge. We're now working for almost 5 months on it to get the data of approximately 50 patients from Finland into our European database. And I think transferring data should be easier, and there should be kind of organization, legislation that allows swift and easy transport of information.
Okay, thank you. We've got a question that I think I'll address to Professor Edwina Brown, because somebody called Juan Carlos Julien Mauro said that it seems that home dialysis options are the best options in times of pandemic for kidneys for patients with KRT. However, at the same time, we've got delays in surgery of peritoneal and vascular access because of the same pandemic issues. You know, how do you manage these competing issues, that it's better for people to be treated at home, but for that to happen, there has to be surgery to make it happen, and surgery is getting cancelled. Is there any way out of this catch-22 loop?
Well, it's going to vary regionally and within hospitals. I was very lucky in that our institution took the attitude that putting in a PD catheter was the second most urgent procedure after a tracheostomy. To avoid people going on to hemodialysis. As I said, our institution was traumatized by the number of hemodialysis patients who acquired COVID and then subsequently died. We also put in local anesthetic catheters. So a lot of it is education. For home peritoneal dialysis to thrive, we need to educate nephrologists to put in their own PD catheters, so we're not totally reliant on surgical ones. So it's a combination of talking to our managers, talking to the people who control operating theatres, and changing culture, that to be able to get people onto home therapies or any sort of dialysis, we need access.
Okay. Thank you. We've got a question that I think lands on your desk, Fiona, because it's about patients. You know, with the advancement of techniques, how do you see the benefit of remote monitoring of patients and the use of remote patient monitoring? So from a patient perspective, obviously staying at home is safer and better. So what are the other benefits, and how do we use remote patient monitoring effectively?
So as you say, the benefits of staying at home are clear. The ability to be able to have blood tests, as I mentioned before, but locally, which can then be monitored by your specialists. That's an opportunity that we haven't yet made the best of, and it seems as though it should be quite simple, but I don't know that it actually is. But I think that the communicating about this as a safe opportunity is something that we could learn from the patient surveys that I shared earlier, and being able to kind of have an open discussion with people that this is a helpful contribution rather than a way not to talk to people, if that makes sense. And if I could also just comment on what Professor Brown just said about the home therapies and I think another benefit is sort of pointing out of the safety of home therapies and where there can be remote access for that. That's something that we can build on with some new technology as well. But I would say that there are hospitals that didn't have quite such a bad time in the first surge, that have not put the same priority on, for example, PD catheters, and are now, there are patients where there is a variation, where there are patients who are definitely not able to get that kind of access, and they really should learn and be able to prioritize it, because as far as patients would be concerned, and many clinicians would be concerned, this is absolutely vital that people get their dialysis access soon, rather than something become a crisis later on.
Okay, thank you. I'm going to pass now to Stefan Schreck, because we've had a couple of questions in specifically about what the European Commission can do. So I think these land on your desk. One question says, look, the evidence that we heard is very clear about the benefits of home dialysis versus in hospital dialysis. What, given that the European Commission, as you've mentioned, doesn't have the power to force change in health systems because it's a subsidiarity issue, but you do have a number of levers like the European semester process, you have country-specific recommendations, you do reports on the performance of different healthcare systems, you're supporting for future preparedness. So within the range of tools that you actually have, what can the Commission do, and maybe guidelines from the ECDC or other agencies, what can you do to help pass this message about the importance of home care rather than hospital care, the training of personnel that Professor Brown has mentioned and Fiona's mentioned, to make sure they're able to do some of these things, recognizing the limitations of the European Commission role, but still you've got some levers at your disposal.
Yes, and we can actually use them. But they all have their shortcomings, if you so wish. For example, the semester recommendations, they're really at a very high level. They would never go to a level of detail like this. So that is absolutely clear. And then it's also what we also, let's say we have limitations from two different perspectives. On the one hand, member states are actually in charge of their health systems, and the question of where dialysis is done is actually a question of really that is to be decided by member states. What we could be doing is, if, for example, there would be a good practice how to arrange this in a given health system, and that would be submitted to our best practice portal, and there would be other member states which want to implement it, we would actually actively help to do that. That is something we could do. We could, of course, also finance projects under the EU for Health program that would actually analyze the situation and indeed offer support to member states to collaborate to change their system in that sense. But again, it would not be us telling member states what they should be doing. It would member states recognizing that they should be doing something, and then we would help them implementing it. So in other words, we are also not in the business to tell member states how a good health system should be function or what good health policy is. That's rather the role of WHO Euro, if you so wish. Our role is to be useful in the sense that we support member states to achieve the objectives they have identified themselves. That's my short description of our role according to the treaty. Okay.
Thank you. Just before we close this panel and we move on, we do have one question from Liam Plant that I think would probably is going to go to Professor Raymond van Holder, because his question was, what proportion of the adverse outcomes in ESKD patients with COVID-19 just reflects the disease biology as opposed to the disruption of the normal care pathways? So the question here is it because the usual care that's so critical for chronic kidney disease patients got disrupted that we saw high mortality, or was it because the COVID itself is acting its own biology? So Professor, can you help us on this?
Yes, I think so. But I think also Professor Gansevoort could further expose on this, because what I do not have is a clear view on the comparison among countries. So I know that in my own country, at least during the first wave, the system was not under pressure. So regarding dialysis, intensive care, etc., and still we have this 30% mortality in Flanders. It may be different in the second wave. We are now really on the verge of the system collapsing. Of course, in Italy and in Spain, and in certain areas, at least the situation was different. So I don't know. So certainly there must be an influence of intensive care unit capacity and so on. But you see from our data during spring that it's more than a capacity problem only.
Okay, Professor Ganserin, is there anything you want to add on that?
Yeah, with our EKHA-led registry, we got detailed information, and one of the questions that we asked was also when a patient was admitted to hospital, whether he or she was admitted to intensive care unit, and if not, what was the reason? And in a certain percentage of patients, it was around 10% of especially hemodialysis patients, it was said that these patients were not admitted to intensive care unit because there were logistical problems, or they anticipated logistical problems to become a problem within the next coming days. So it has been part of the problem of high mortality. And it's not only the explicit collapse of a system, it is also the anticipation of doctors, because from my own family, I know that an uncle at a certain age of 82 was not admitted to intensive care unit, although he was very, very vital, because they thought, let's not do it because the system is nearly collapsing. We need every space. And when we admit this man to an intensive care unit, what will happen? He will probably be there for 6 weeks. Recovery will take a lot of time. So implicitly, people are already making decisions about intensive care units admissions or ventilator support that are driven by the thought of a common shortage. So I do think that there is a kind of hidden problem here in that high mortality, that it's not only biology, but that it is also the logistics of our hospitals.
Okay, thank you. I also moderated an event with the cardiovascular community, and they were saying that one of the reasons that they had high mortality, particularly in the early stages of the first wave in Italy, is that in the Lombardy region, they have very well developed hospitals, and most care is delivered in hospitals, very little in the community. So you brought all of the older people into hospital to have treatment for cardiac disease and everything else, and that then became the vector of transmission. So I mean, we were asked, you know, why was is it the high mortality due to the disease itself or disruption of care? And in some cases, it's actually that care was delivered in places that increased risk. So I think this is Professor Van Holder, yes, you want to add something?
I would like to add something else. That is that if the system is overloaded, you get, of course, also a decrease in treatment modalities for other chronic diseases that have no COVID at all. I think that is very important. I know that in our own hospital during the first wave, we had very many patients with acute kidney injury, but half of them had no COVID. So that was just simply because they came in too late and developed acute kidney injury for other reasons.
Okay. Thank you. Well, I think this has given us a very nice bridge to the second panel conversation that I wanted to have, which is, you know, how do we ensure that the lessons that we've learned, some of them very hard lessons, get used in the way that we plan our health systems for the future? Because it's very clear now, for years, we've been talking about the need to shift the paradigm away from sickness care to prevention and better primary care, but nothing's moved. And yet now the eyes of all the political leaders is on healthcare systems, and there is a commitment to reform them, to make them more resilient and they're able to cope better. So from our perspective, for looking at the area of chronic kidney disease, what lessons do we think should be learned so that in the conversation about reforming our healthcare systems? I'm going to start with Professor Edwina Brown. You know, what were the barriers that existed previously to unlocking the potential of these new alternative ways of treating rather than being in hospital with dialysis? What were the blocks before, and do we now have an opportunity to remove those blocks, to really roll out these therapies that are safer and more effective?
I could go on forever about that, but this is certainly an opportunity. The main barriers were patients or people not knowing about the availability of home therapies and institutional or cultural biases from healthcare teams and also healthcare systems which favor hemodialysis, you know, bums on seats sort of attitude. So we've certainly got changes things that we can do to change that. For a start, we need to think about how do we talk to people who are about to start on dialysis or need to make those decisions. The one-to-one, face-to-face discussions with potentially biased healthcare professionals are now limited. So certainly in the UK and in our own institution, we are developing information and learning sessions and webinars like this for patients. So this is becoming more centralized and therefore gives an opportunity to deliver less biased education. We also need to think about how do we educate healthcare teams to deliver peritoneal dialysis, and if there's a wish for that, that will happen. And the other block was the biggest proportion of people on dialysis is actually the older population. Many of those people can't actually do their own peritoneal dialysis. And in some countries, like France, the availability of assisted peritoneal dialysis has been there for decades. It is still fairly new in the UK and is of limited use across other parts of Europe. And the availability of technicians who really require minimal training to go into people's homes and enable them to do their own dialysis is still going to be cheaper and cost effective than bringing people in on socially distanced hospital funded transport into hemodialysis units. So I think what we need to develop to get over the barriers is unbiased education, the availability of assistance, and a change in culture amongst people responsible for healthcare delivery, that home is best.
Great, thank you. Let me turn to you, Stefan Schreck, now, because the Commission is about to put forward some very big proposals on how we could have a European health union, a health data union, and the focus is very much on how to support healthcare systems to be more resilient, how to prepare to manage some of the issues more effectively. How do you think the lessons that we've learned over the last 8 or 9 months are going to be built into that? And what do you think that patients from the chronic care community might expect would be different in the new proposals?
Yeah, I mean, it is really obvious that indeed we need better sharing of data among member states to have better analysis at European level. That's quite obvious. And that's the whole idea between the European health data space, which became even more prominent now in the wake of COVID-19. But it is also clear that let's say what it will achieve will actually depend on many different aspects of how it will be implemented. It is, for example, clear that member states that provision of data from a given member state to a central European database, for example, is completely voluntary. So there's nothing that can be done about it. So if member states don't want to cooperate, it's very difficult. That's it's easier for infectious diseases. There we have the ECDC in Stockholm, and member states are usually providing data, but even there, the data that are provided are not always ideal. In other areas, we don't even have an ECDC. We have a limited collection of data by Eurostat, the statistical office of the European Union. We have the cancer information system, for example, which is run by the Joint Research Center in Italy, in ISPRA. But from all those experiences, we know it is very difficult to persuade all member states to provide data according to a defined data set with a defined frequency and a defined quality. That because it simply creates costs for those who have to provide the data. So that's one issue. The other issue, as we can see also now, for example, in the framework of the European reference networks for rare diseases, that there's also the General Data Protection Directive, which makes it very difficult to transfer health data between member states and to European institutions. There was a long discussion about this European General Data Protection Directive. And it is just a fact that it is not facilitated by this legislation. There might be an effort actually to improve that situation. There might be a project financed under the health program to actually develop something like a code of conduct for national health authorities that will facilitate exchange of data across borders. There is general awareness, and also there will be availability of funds for creating this European health data space, and indeed that should contribute to a collection system for chronic diseases, including CKD. But it is difficult. What I should also say here is that one of the things we have seen in the past, many initiatives to collect data at European level have been financed by projects under different programs of the European Union. But these projects basically all have the disadvantage that they have a beginning and an end. And we have seen many databases collapsing after the end of project financing because there was simply no more money to continue that and to update them regularly. And that is a problem that essentially under the financial regulation we have at the moment can only be solved by creating something I would call an institutionalized solution. And that is actually quite difficult to do. If you want to create new agencies at European Union level, you will run into a lot of political opposition that we have also seen. But what I should actually be saying or not forget to mention is that what we are having in the area of kidney diseases is the EKHA-led. That's an ERN for rare kidney diseases, and they are actually working on a registry project to establish an online platform for the collection of information relevant to patient health and clinical research. Of course, this is only for rare disease patients, but in a way, it's a start if you so wish. Okay. And so maybe I should not talk much more.
Well, I mean, there's plenty to say, but before I do, could I just check? I mean, you said it's hard to create a new agency, but they've just announced we're going to have a new BARDA, which is going to be a new agency looking at research and technical development. Is there a chance that this might be the institutionalized solution to these separate registries being set up by projects?
It is really too early to talk about that. BARDA for the moment is basically just an idea, and colleagues are working on filling this with life.
Right.
But let's say, as BARDA is actually a US institution and does not exist at European level, and if you look at what the US BARDA does, well, it is difficult to imagine that this would be the right type of agency to collect and analyze data for specific diseases, to put it like that. Okay. But who knows how this will develop? It's really too early to talk about that.
Okay, thank you. Let me bring in Professor Ron Gansvoort, because I saw you nodding when Stefan was talking about some of the challenges of this and the GDPR, which is in theory about the protection of our personal data, but that then adds these barriers in transferring data. And you talked about the challenges of these poor 50 Finnish patients who want to get their data included, but somehow it's not working. So what can you share with us about the challenges of creating a cross-border space for data to be used?
Yes, I listened with much interest to Stefan Schreck and him stating that it's not up to the European Union to make it mandatory how member states organize their care. But still, I think there could be a role of the European Union. At least I hope there could be. We've got the renal registry, and it covers now around 70% of Europe. And I think there should be a way where the European Union could help us to get a 100% data set to get better insight of the pandemic of chronic kidney disease in the European Union. That's one another issue where the European Union could be of help. I see when I look at the site of Eurostat all kinds of information about non-communicable diseases like diabetes, heart failure, hypertension, etc. But although chronic kidney disease has a very high prevalence, and as Professor Ravenholder has shown, is associated with so much morbidity and mortality, I think it's surprising to see that chronic kidney disease is most of the times not on the list of Eurostat when they mention numbers of patients affected in the European Union by these non-communicable diseases. So CKD should really have a place there, and I hope that the European Union can stimulate that.
Okay, thank you. Professor Raymond van Holder, I think you wanted to come in, and I'll also then bring in Professor Fokker-Wieringa, because you've put some things in the chat that might be worth sharing. Professor van Holder, yeah.
2 points. The first point is to Mr. Schreck. I'm aware of the fact that that this is usually used as an argument that the competence of the EU is lower in health matters. But of course, as far as I understood, one of your things that you are more able to act is on patient safety and of quality of treatment. And this matter is really about patient safety and quality of treatment. So maybe I'm wrong that my terminology is not right, but somehow I think this could be managed in that direction in the same way as we did for transplantation. And the second point is about Eurostat. As a matter of fact, this year they gave statistics about kidney disease, but they were obviously wrong because it was a huge underestimate. The estimation was probably right for kidney cancer, but then what was left was about 1/3 of what we are aware of, that is patients with chronic kidney disease. So probably also their system could be adjusted to get more correct results.
Okay, thank you. Professor Wieringa, do you want to come in on some of the elements we talked about, good practice and how to get the new guidelines to be more appropriate and some of the incentive mechanisms?
Well, indeed. Well, I think that Stefan Schreck really points out a very appropriate point. There is a large costs versus incentives component on many things, on innovation in this area, but also on maintaining data sets and exchanging stuff between the countries. That is really a thing. And also the standardization of the format of some of the data. I think in that way, the European initiative Elixir seems quite a promising thing, because that takes account of the data privacy aspects. It's a very clever solution on that. It was funded by the EU, which I think they should be praised for. And it seems like it would be a usable infrastructure to strengthen the cooperation between countries, because Elixir has many countries working already together. Also, another good thing that the European Union did is that they funded a project to develop a functional and really working PD cycler, automated, that can disinfect its own catheter connector, and is very good also in optically monitoring the dialysis quality. So taking a lot of the work that the nurse or the technician would do, being done by the machine and calculated. So Europe does a lot of good things already and is really trying to reach out. The trouble probably is the general perception. So all of us, policymakers or ordinary people or even scientists, if my doctor would say to me, Dr. Wieringa, you have cancer. My world is colliding. I'm struck by lightning, and everybody has that. Oh man, the C word, cancer. But if they say to you, well, you need dialysis to survive. Oh, fortunately, there's dialysis. Grandma nudge you on the shoulder, said, well, good, there's dialysis. So at least you'll be living. And the impression in the general audience is that it's not such a bad thing. You can be 100 years if you just go 3 times a week to the clinic. And that perception, although the numbers indeed say different, but that perception is not there yet. And basically, the good news is in cancer, a lot of good work has been done. The fact that now people with end-stage renal disease are becoming higher on the mortality top 10 is because in cancer, there has been such good work with better prevention and better treatment that these chances of people have improved. And so also for cardiovascular. So now it's time to also put our attention to end-stage renal disease, but also prevention of chronic kidney disease. Okay, sorry to interrupt on that too much.
No, thank you. And you actually gave me a fantastic bridge to what's going to be the last question of our panel session, which is precisely this issue around prevention. Because the data shows that if you get to the point of having chronic kidney disease, your outcomes are really not very promising. And so what do we do to prevent this? How can we stop the pipeline of people coming of people who have this disease? So Fiona, let me ask you from that. I mean, we had a challenge there from Professor Werringen, which is there is little understanding in the public about just how serious kidney disease is, maybe also how it develops and what it does. So if people don't think it's such a big deal the way they do about cancer or heart disease, how do we focus on prevention? What should people do for prevention, and how do we make it clear to them the implications if they don't prevent?
Yeah, I think it's a really good challenge, and it's something that kidney patients feel incredibly distressed about, I suppose, particularly at the moment where the numbers of infections are so very, very high. But my first point actually is as others have said, is about prevention. So if there is something that comes from this, to know that chronic kidney disease itself at the earlier stages, can be by being identified sooner, by having the conversations with patients. So using the opportunity to say, hey, you have high blood pressure, you have diabetes, to pick it up now, to inform people what they might be able to do with that. Because we would all far, far rather concentrate on prevention of deterioration, because even if somebody is heading towards kidney failure, delaying it by 10 years, makes a huge difference. So to identify those people who really are at risk of their kidneys declining, and to work with them, and to use this opportunity to raise awareness of chronic kidney disease, so that if something goes wrong with the kidneys, but acute kidney injury, a good phrase actually is a kidney attack. And sometimes people can react to that in a way they haven't reacted it to before. So maybe we can use acute kidney injury as one of the wedges. We could also use incentivization. So there has been some good work done previously. It has disappeared now in the UK, for incentivizing people in primary care to be able to pick up and to address this issue. So for all the messages, picking up the earlier stages of CKD, because the numbers show, and you won't necessarily be able to see that on my slide here from the UK Renal Registry, but the numbers show how very high, even that people with later stage chronic kidney disease are also there. But if we take that out, to something like 5,000 infections and 1,500 deaths for people with CKD, dialysis and transplantation, those are high numbers. And so working with the media as well, and also to take that opportunity to work with the charities, to work in collaboration across Europe. And I know we have Brexit, but diseases still cross those borders. We are still part of the European Kidney Patient Federation and the UK, the European Kidney Health Alliance. So to use the data that we've got, to share it, to use the renal registries that we have, and the willingness of patients and their families and our clinical colleagues together to make that case, to work with journalists and other media, but to bring in and challenge our governments to incentivize some of this opportunistic collection of people to prevent and highlight this issue where there is sometimes something we can do about it.
Fiona, before you close us off, in many other diseases, we've got some very simple messages around prevention. Around diabetes and cardiovascular disease, it's move more, eat less, drink less alcohol, don't smoke. So we've got some really simple messages. What should be the key if somebody wants to protect their kidneys, and if you said, delay acute kidney injury by 10 years, what is the message we should be telling people? Can we synthesize them?
Well, I think that's where we need to get some decent agreement actually between us, because it is part of the same messages with diabetes and high blood pressure as well. Not for the genetic conditions like I have, because that's different, but for those that can be prevented, as you say, move more, eat well, low salt, keep your fluids up. Those are the very simple messages for general kidney health. And the more we can do to say to people, there is no health without kidney health, that would be the goal that we could achieve. Simple,
great,
direct.
Thank you. And I'm going to draw this panel to a close because we've run out of time. And it was thank you very much to all the members of the panel. Your inputs have been really valuable and interesting. And I think our audience will have found it useful. And this, as I said, has been recorded, so it can be shared with a broader community. All the PowerPoints will be available. Some of the data was really quite startling in the way it was presented. So I'm sure we're going to need to take it away and use it for advocacy messages. So thank you to all the members of our panels, to Fiona, to Professor Edwina Brown, to Daniel Gallagher, Professor Ronald Gansfort, to Professor Focke Weringer. Thank you so much. I'm going to now hand over to Professor Raymond Van Holder to wrap up this webinar on our behalf and to share the concluding messages.
Okay, thank you very much. I must thank all the panelists and all the people also taking part in the discussion via the different channels that we have available to make this session so lively and so informative. So I think there is no discussion that chronic kidney disease is a very important and bothersome problem, a neglected problem, a problem that is not known to many people. And we have a huge task in front of us to increase the awareness on this disease. And I think that is one of the first tasks that is there. And that's the responsibility of us all, of the whole community that is involved with this as well. The patients, as the doctors, as the nurses, as the policy makers who need to inform each other and to talk to each other. And this includes also the industry, the manufacturers of drugs and of treatment modalities like dialysis. So that's a first point. The second point is that on top of that, there is work to be done to improve the prevention of this disease. And this is not only about secondary prevention, because that comes always when it is too late. You can refrain the progression of kidney disease, but you cannot stop it or you cannot turn it around, at least not with the means that we have available nowadays. So this prevention includes also primary prevention, which is about lifestyle, about healthy diet, and not to forget, and that's a European competence, about environment, because there's a lot of pollution, and this pollution is also influencing kidney disease. And then there is also this task of bringing the treatment from the hospital to the home. I think that's a universal evolution, but home dialysis treatment must in many different ways be propagated better together with kidney transplantation. And then as a last point, we need also more research on kidney disease and more innovation. And like Professor Wieringer said, what has been accomplished for cancer is something that we could accomplish also for kidney disease. And for that, we need more innovation and more out of the box thinking. Finally, I think that to make all this possible, we need more and more precise data. And those data are available. They need to be analyzed, but it will be more informative to change mentality and therapeutic approach. And as I have understood also, we as a community should make recommendations to the European Union and policymakers of what needs to happen. About COVID, I think that all the things that apply to the general situation apply to COVID as well, with this extra point that what will be developed as treatment and as vaccination needs to be evaluated in the kidney patient community. And based on all these elements, let's work together to improve this condition and to bring a better life to our patients, and a new extra positive project and perspective to the caregivers. I thank you for your attention.
Thank you very much, everyone, for participating. Have a lovely and safe day. Wear your masks, wash your hands, drink water. Thank you and goodbye.